Hello, I'm David Tony, Head of Global Sales for Neodent. I have the opportunity to sit down today with Dr. Carlos Araujo, clinical professor at the University of Sao Paulo, as well as a practicing clinician. Dr. Araujo, thank you today for an absolutely wonderful presentation. I must say I've never seen histology slides like the one you showed today. It's quite impressive. Could you tell us a little bit about your history with Neodent?
Well, a series of coincidences took me near Neodent. In fact, my wife was doing a post-graduation study and she needed a subject for her thesis, so we decided to study surfaces. So I contacted many companies internationally, and Neodent was the very first one to answer us, and they offered to help us with the project because they also needed to develop a new surface. So that was our first contact. Then Dr. Geninho, the former president of Neodent at that time, he found out that I was very much connected to the cone morse or the morse taper prosthetic connection in implants. And so he invited me for us together to try to develop a Brazilian system with a cone morse connection. And then we started to work together, and it has been like this for the last 13 years.
And if you were to summarize what you think the clinical benefits are of the cone morse connection, how would you categorize them in terms of?
I was always very excited with this system since I met it in 1996, because it starts from the point that looking from the patient side, you don't have any smell, you don't have any bad breath, so that's amazing for the patient to know. But that comes because you have a much more healthier soft tissue around this implant. That brings a more aesthetic look, a more pleasant look, and that also brings one of the most important things we achieved in implant dentistry, which is long-term stability, endurance, and it maintains the soft tissue for tenths of years in the same aspect, in the same aesthetic, in the same healthy aspect. So it's I believe that nowadays every company in the world is trying to follow us, if I can say that, because everybody's wanting to have this very, very interesting connection.
The slides that you showed today obviously showed some incredible tissue response. One in particular I've not seen before was you showed a slide that had epithelial attachment to the abutment. Was that a fluke? Was that a one-off type of thing, or are you prepared to say that you can consistently get soft tissue attachment to abutments?
Thank you for this question, because this is one of the points I most adore. Indeed, it's a frequent and it's a routine finding. As soon as we learn that the implant, when you have this very stable and very clean connection, the implant can be installed subcrestally, what means under the bone level, then automatically all the tissues get organized in a different way compared to what we saw before in conventional implants. So you will consistently have bone covering the top of the implant, and so all the other tissues that we studied for years and tried to improve their connection to the implant, now we can connect them to the abutment. So the next step is to develop an even better abutment so that we can take advantage of these findings.
In Brazil, I was quite surprised and intrigued to learn that not only is immediate loading standard protocol for implants, but you go to the final abutment, a standard final abutment routinely in Brazil. What does that mean clinically for your patients that you do that?
That's another very interesting point. We found out that because hard tissue organizes itself in contact with the abutment, if you place an abutment, as we did in a routine basis before, or if even worse, if you are used to take an impression of the implant and send it to the lab, you are going to have to switch components many times on top of that implant. And that means to disturb the intimacy of the relationship between the abutment and the bone tissue and the soft tissue. So we found out, even though this is not absolutely demonstrated scientifically, we're working on this right now, but we found out that the least you touch the abutment, the best for the tissues. So we try to teach our clinicians to use their selection kit and to learn how to use it, to be able to, at first, select an abutment that might be the final abutment. And that, with little training, becomes easy, becomes something that any clinician can do.
Obviously, being involved with Neodent for so many years, how well would you say the system is documented from a scientific study point of view?
I'm very happy with this. When we began, that was one of the main concerns. But I had the opportunity to conduct several studies, and we organized a group in Brazil and also abroad to start a very strong project in terms of conducting studies to support the system. Now I think we have a very good documentation. We have publications in several impact journals. So right now I think we have a completely mature system in all terms, clinical terms and scientific terms.
Well, outstanding. Well, I must say, I congratulate you again on a wonderful presentation. I think some slides and some histology were shown today that no one has seen before, so you enlightened a number of people today, and it was extremely well received. So I want to thank you again very much for traveling to the UK for this presentation.
Thank you very much for being here. Thank you.